Dr. Trivedi, having been involved in the review and the development of guidelines, how can these be used effectively in parallel with educational activities to help clinicians?
I think guidelines are really a very good place for looking at the synthesis of the current evidence and the breadth of what is going on in the field. And those then have to be translated into practice algorithms for different settings or different circumstances. And that's, I think, where the work of CME-related work comes in, where we distill that, what is in the CANMAT or the APA guidelines, into saying, what is the evidence that waiting for sequential serial monotherapy trials is worthwhile? And the answer may be not, and that may be something that we do through CME, because guidelines really are not likely to be able to keep up with it. Or, for example, even if the CANMAT guidelines were approved just a couple years back, now that we have esketamine and brexanolone and TMS and the theta burst, et cetera, where does it fit? That will take time for CANMAT guidelines to be updated. So I think organization, CME activity is where the action will be.
You make an important distinction between guidelines and algorithms, and I think, in my personal view, both are important. Dr. Jackson, in your clinical practice, or in your kind of group of peers, do internists use algorithms for major depressive disorder, or do they tend to follow kind of a different approach or a more educational-based approach? How are decisions to augment or to switch or to change treatments made?
I think that those decisions, unfortunately, can sometimes be haphazard and highly individualistic. If I were to take a less idealistic view, I might say that it's based on the last intervention that the clinician received education on, and that's the idea of the less bird's eye picture and the more focused picture of education. And so, a clinician may have received good education about a particular intervention, but if they didn't get the full picture, then they might just be, they've got their hammer and they're out there looking for the next nail. They're a one-trick pony, so to speak, to switch analogies. I think that in primary care, we really want algorithms to guide us. We greatly respect the research, robust richness that you guys bring to the table, but we really need the guidelines are great, and here's the status of the research, but how do we, dumb it down for me, if you could pardon that phrase, to this, if this happens then, if this then. And some of that has to be evidence-guided, I think, more than evidence-based, because you may not have 4 randomized trials showing that this is better than that. But, I think today we can probably say that an augmentation is better than a switch in most cases. And so knowing that is key.
Dr. Rafay, and from your perspective, a different perspective, an academic-based psychiatrist, how do you and your peers make these kind of decisions? Do you use algorithms? Do you use more individual-based care? If you could give us a little bit of an insider view.
Sure. It's it ends up. So definitely, as being a educational institution, there's emphasis on making sure all our residents know all the guidelines and they're familiar with it. So inadvertently, that comes into the decision-making process of what the guidelines are out there and what's the evidence behind having those guidelines. On the other hand, there's a lot of emphasis on what has been published and what the evidence is. What is the scientific evidence behind the intervention? With that said, we still have our own individual biases. We all have our own individual favorites of approach and algorithms that we utilize. So that variability is also seen within a department, as of how everyone approaches the approach. So it was quite diverse. It really is diverse.